Okay, let's go.
Welcome back to another deep dive. Today, we are going to explore really the absolute edges of human consciousness.
Yeah.
We're digging into a class of drugs that don't just warp how you see the world, like a standard hallucinogen might, but actually threaten to disconnect you from it entirely. We're talking about dissociative states.
It's a literal and, a figurative break.
Yeah.
And while that experience might sound like something from sci-fi, maybe a trippy movie, the clinical reality we found in the source material is it's gritty, it's dangerous, and incredibly complex.
We have a really heavy stack of sources today. Clinical papers, the DSM-5 criteria, a lot of epidemiological data, and some medical primers on pathophysiology. So our mission is to strip away the street mythology, the angel dust and special case stuff to really understand the mechanics.
Right.
We want to know how these substances hijack the brain's communication lines, and specifically how we define and treat the use disorder that comes with them.
Yeah. And that distinction is just so vital. The difference between, say, recreational use and the actual clinical disorder. We often see these drugs through a pop culture lens.
Oh, absolutely. The wild party drug or the
Yeah.
terrifying face-eating news story.
Exactly. But when you look at the medical literature, you see a specific pathology. You see a brain that has just stopped processing input correctly.
Okay, so let's dive right in. Section 1 of our notes groups two heavy hitters together, phencyclidine, which is PCP, and ketamine. Why bundle them?
Yeah, that's a good question.
Usually drugs get their own chapters in the textbooks.
It really comes down to their chemical architecture. They are classified as PCP-like substances. So phencyclidine is the prototype. It's the original.
Yeah.
But then you have these structurally similar compounds, analogs like ketamine, cyclohexamine, diazepam. They might have totally different street reps, but, pharmacology doesn't really care about marketing.
Right.
In the brain, they are hitting the exact same buttons.
Let's do a quick roll call of those reputations, just so we're all on the same page. PCP, that one usually has the darker nicknames. The notes list angel dust and embalming fluid.
Embalming fluid is a particularly grim one, but it is descriptive. PCP often comes as a liquid. It can be ingested, sure, but more commonly, that liquid is used to dip cigarettes or joints. Or, in powder form, it's just sprinkled onto leafy stuff, cannabis, mint, whatever, and smoked.
Which introduces this, a terrifying variable.
Yeah.
The user who doesn't even know they're taking it. If you just bum a cigarette at a party.
You might have no idea that it's been dipped. Then you have ketamine, Special K, Vitamin K, Kit Kat.
A very different vibe.
Different origin story, too. It was developed in the 1950s as a medical alternative to PCP, actually.
Oh, really?
Yeah, PCP was a decent anesthetic, but the side effects, the delirium, the agitation were just too severe for surgery. So ketamine was the gentler cousin. It's still used in hospitals, vet clinics today.
Wow.
But recreationally, you see it as a powder to be snorted or a liquid to be injected.
So we know what they are. But the core of today's deep dive is the effect. The literature keeps using this one word, dissociative. To the uninitiated, that sounds kind of vague. I'm dissociating. What does that actually feel like based on the report?
It's profound. At lower doses, the source material describes a sensory detachment. So imagine you are driving a car, but suddenly you're not in the driver's seat. You're hovering above the car, just watching yourself drive.
Wow.
Or maybe your body feels like a machine that you are operating by remote control.
That sounds like depersonalization.
Exactly that. It is a separation of mind and body.
Yeah.
You're not just seeing trailing lights. You are fundamentally questioning the ownership of your own limbs.
Okay, let's pop the hood on that.
Yeah.
Mechanically, inside the skull, how does a chemical achieve that kind of split?
Yeah.
This is where the notes get dense with NMDA receptor antagonism.
Right. So let's break that down. The NMDA receptor is a primary receiver for a neurotransmitter called glutamate. I like to think of glutamate as the brain's yes signal. It's the main excitatory messenger. It tells neurons to fire. It's how you process pain, memory, spatial awareness, all of it.
So glutamate is like the brain's internet connection.
And PCP and ketamine are the wire cutters. They're what we call non-competitive antagonists. They basically jam the lock. They sit in that receptor and just prevent the signal from getting through. So your hand touches a hot stove, the nerve sends the signal, but when it reaches the brain's processing center, nothing. The line is dead. That's the blockade.
You are literally ghosting your own nervous system.
Yeah.
That explains the pain thing, which is a huge part of the danger here. But I found a detail in the body and brain section that it stopped me cold. It's the timeline.
The pharmacokinetics.
Yeah. The paradox of timing, let's call it. The notes say the psychoactive trip, the high, it only lasts a few hours, 4 to 6 hours.
Generally, yeah.
But the drug itself, it doesn't leave.
This is a crucial insight, especially for toxicology. PCP is highly lipid soluble. It loves fat. So while the brain effects might wear off as the drug redistributes, the molecule itself gets stored in your fatty tissues. The elimination half-life it's incredibly long.
How long?
It can take 8 days or even longer to fully clear the system.
8 days. So you use it on a Saturday? By Sunday morning, you feel sober. But on Wednesday or even the next Friday, that chemical is still leaching out of your tissues.
It is. And think about the implications for drug testing. A standard urine screen can pick up PCT for a week or more after just a single high dose.
Wow.
It's a silent passenger. The party is long over, but the guest has not left the building.
That lingering presence feels ominous. It makes me wonder about the cumulative effect if someone is using it every weekend. They're never really clean.
Precisely. You're constantly stacking that chemical load in your body.
Okay, let's shift to the emergency room. Patient comes in, confused, maybe agitated. How does a doctor know it's PCP and not, say, a severe alcohol blackout or a manic episode? The sources list some physical tells.
Yeah, there's a triad of symptoms that points heavily to dissociatives. The first, and maybe the most distinct, is nystagmus.
The eye wobbles.
But specific ones. With alcohol, you might get horizontal nystagmus, eyes jerking side to side. With PCP, you often see vertical or rotary nystagmus.
So up and down or rolling.
Exactly. The eyes are jerking up and down or rolling. It's involuntary, it's hard to fake, and it's very unsettling to watch.
And that's combined with the second tell. Analgesia.
Complete numbness. Remember, these were designed as anesthetics. A patient might have a broken arm, a severe cut, and they're completely indifferent to it. They aren't acting tough.
The signal just isn't there.
The pain signal literally is not registering. And the third is hypertension.
High blood pressure.
Right. So if you have a patient with rolling eyes who doesn't feel pain but has a racing heart and super high blood pressure, that's your clinical picture for PCP intoxication.
But it's not just a bad trip. The severe risks section of our notes, it reads like a horror script. We're not just talking about anxiety.
No, not at all. We're talking about system failure. The most acute risk is often rhabdomyolysis.
Okay, that's a big word. Break that down for us.
It's the rapid breakdown of muscle tissue. Maybe from physical exertion, like struggling against restraints, or maybe direct toxicity. The muscle fibers dissolve. They release a protein, myoglobin, into the bloodstream.
And the kidneys can't handle it.
They can't filter it. It just clogs them up. You can go into acute renal failure very, very quickly.
So your own muscles end up poisoning your kidneys.
Precisely. And you can add to that the risk of intracranial hemorrhage bleeding in the brain from that crazy high blood pressure or seizures or respiratory arrest. And let's not forget temperature regulation.
Hyperthermia.
The body forgets how to cool itself. Patients can overheat to fatal levels. Or, the opposite, hypothermia if they pass out in the cold. At very high doses, the lights just go out. Stupor, coma, death.
That's the acute phase, the I took too much right now problem. But what about the chronic user, the person doing this regularly? The notes mention cognitive deficits that don't just clear up on Monday.
And this is the long shadow of the drug. Chronic use leads to these persistent issues with memory, speech, executive function. The sources note these deficits can last for months after the person stops.
Months.
You might find yourself stuttering, unable to find words, struggling with simple tasks long after you've quit. The wiring takes a very long time to repair itself.
Which brings us to the central question of this whole deep dive, the diagnosis. How do we cross the line from just hazardous use to a clinically defined use disorder?
For that, we turn to the DSM-5. The diagnosis isn't about how much you take, but about how much chaos it introduces into your life. You have to meet at least 2 of 11 criteria within a 12-month period.
And these criteria fall into a few buckets, right? There's the loss of control bucket.
Taking more than you intended, and I'll just do a little, and suddenly 3 days are gone. Or trying to quit and failing.
And then the life impact bucket.
Spending all your time getting the drug, using it, recovering from it, failing to show up for work, for your kids, for school, giving up hobbies you used to love.
And risky use.
Driving while dissociated? I cannot emphasize how dangerous that is. Your depth perception is gone, your reaction time is gone, or continuing to use even when you know it's causing you, say, depression or bladder issues, which is a specific problem with ketamine.
But here's where the deep dive got really interesting for me. There is a glaring hole in the criteria, a real twist in the logic of addiction.
The missing criterion.
Withdrawal.
This is something that fascinates specialists in addiction medicine. For alcohol, for opioids, benzos. Withdrawal is the hallmark. You stop, you get sick, physical tremors, nausea, seizures.
Yeah.
But for PCP and ketamine use disorder, the DSM explicitly states withdrawal symptoms and signs are not established.
That seems impossible. You can be addicted, but if you stop, your body doesn't revolt.
In humans, no. We just haven't documented a consistent physiological withdrawal syndrome. We've seen it in animals and lab settings, but for a human user, stopping doesn't trigger that classic, flu-like sickness.
So technically, withdrawal is not a box you can check to diagnose this disorder.
Correct. And that's dangerous because it gives users a false sense of security.
I'm not shaking, so I'm not addicted.
Exactly. But the psychological grip, the craving, which is a criterion, can be completely overwhelming. The addiction is driven by the desire to return to that dissociated state, not by the fear of getting sick.
It really reframes the whole concept of dependency.
Yeah.
It's behavioral, psychological, not just a physical leash.
Right. Now, we need to talk about the mental state. We touched on the dissociation, but the notes go into something much darker. The schizophrenia mimic.
This is why PCP is a legend in psychiatric wards.
It is. The intoxication can mimic the symptoms of schizophrenia so perfectly that it can be impossible to tell them apart in the moment. We're talking hallucinations, delusions, disordered thinking.
And the duration isn't always short, right? It's not just while you're high.
No, and this is the truly scary part. In some people, this psychotic state can persist for weeks. Long after the drug has technically left the receptors, the user is still stuck in this distorted reality. Imagine believing a complex conspiracy theory about your own family, and that belief just will not break for a month.
That leads directly to the violence issue. We have to address the stereotype of the violent PCP addict, the guy breaking handcuffs, fighting 6 cops. Is that real, or is that just Hollywood?
It's a mix, but the cause is so misunderstood. The media portrays it as, roid rage, pure aggression. But clinically, it's almost always driven by paranoia.
So they aren't attacking, they think they're defending themselves.
In their mind, yes. Their reality testing is broken. They might hallucinate that the paramedics are demons or that the police are trying to execute them. They are, in their minds, fighting for their lives.
You combine that terror with the analgesia, they can't feel pain, and the adrenaline dump.
And you have a person who doesn't stop when they're tased, doesn't stop when they break a bone, and that looks like superhuman strength, but it's really a body pushing itself past its breaking point because all the safety limiters are just turned off.
It's a tragedy of perception. Now, zooming out to the population level, who is actually using this stuff?
The epidemiology is a little murky. The prevalence of the actual disorder is listed as unknown because it's just hard to track. But we do know about 2.5% of the U.S. population has tried PCP and maybe 1–2% for ketamine.
And there's a really distinct gender skew in the ER data.
A massive one. About 75% of PCP-related ER visits are male. It suggests that the demographic engaging in the kind of high-dose, risky behavior that lands you in the hospital is overwhelmingly male.
What about risk factors? Do we know who's susceptible to this?
Surprisingly little. Unlike, say, alcohol, where we've mapped out genetic markers and environmental triggers, PCP use disorder is still a bit of a black box. The notes literally say little is known. It's an unpredictable beast.
So we've got a dangerous, unpredictable drug that mimics psychosis and hides in your body for a week. The million-dollar question. How do we fix it? Is there a pill?
This is the hardest part of the conversation.
Yeah.
There is no FDA-approved medication for PCP use disorder.
No methadone equivalent, no patch.
Nothing. We have drugs to treat the symptoms of intoxication, benzodiazepines, to calm a seizing patient, cooling blankets for hyperthermia. But for the addiction itself, the cupboard is bare.
So what is the standard of care? You can't just send them home?
We have to rely on behavioral therapies. The notes really highlight motivational interviewing.
Which is what, exactly?
It's a counseling style. It's not about confrontation. It's not a doctor wagging a finger saying drugs are bad. It's collaborative. The therapist helps the patient explore their own ambivalence about using.
So like?
On one hand, you like the escape. On the other hand, you lost your job. Let's talk about that gap. You try to get the patient to argue for their own change.
That must require a lot of patience. And it gets even more complicated when you consider the adulterant factor mentioned in the notes.
A critical point. A lot of people who present with PCP in their system never asked for it. It's often added to cannabis or cocaine to boost the product.
That has to be a psychological nightmare. You think you're smoking a joint to relax, and suddenly the entire world dissolves around you.
And clinically, treating that patient is a totally different ballgame. They don't have a use disorder in the sense that they were seeking the drug. They have a trauma. They were poisoned. The doctor has to be incredibly careful to distinguish between the recreational user and the accidental victim.
It just underscores the total lack of quality control in the illicit market.
Yeah.
You never, ever truly know what you're getting.
You're playing chemical roulette every time.
Okay, let's wrap this up. Let's synthesize what we've uncovered here. We're looking at substances, PCP and ketamine, that work by basically cutting the communication lines in the brain.
Specifically the NMDA receptors.
Yeah.
Resulting in a state where the mind is present but the sensory input is just severed.
And that state creates a kind of zombie-like immunity to pain, which leads to severe physical risks, while also creating a paranoia that can look exactly like schizophrenia.
And while the user might feel normal the next day, the molecule is lingering in their tissues for over a week. That silent passenger that complicates testing and maybe contributes to long-term damage.
The big takeaway for me is this redefinition of addiction. It's not about the shakes, it's not about vomiting, it's about the behavior.
And it's a reminder that the brain is so fragile. You can't just flip switches in the glutamate system and expect everything to bounce back perfectly. Hallucinogen is really too soft a word. These are dissociatives. They dismantle your reality.
Before we sign off, I want to go back to that thought you shared in prep, that timeline issue.
The 8-day window, yeah, it haunts me a bit. If the subjective trip is 4 hours, but the chemical is there for 8 days, what is it doing in the background that whole time?
Right.
We know about flashbacks, hallucinogen persisting perception disorder. We know about the cognitive deficits. It all suggests that the chemical imprint is far deeper than the temporary high. We are potentially rewriting neural pathways in ways we don't fully understand during that silent week.
A very sobering thought. The party ends, but the brain keeps keeping score. If you want to see the full list of diagnostic criteria or the clinical notes we used, check out the show notes.
Stay curious, but stay grounded.
Thanks for listening to The Deep Dive. We'll see you on the next one.